Jason.
So hi everyone, again, I'm Alex. I am the new EMS fellow, so one of the UC docs, and we'll be going through kind of several different cases, a couple different themes that seem to emerge this month. So hopefully what we talk about is interesting and helpful to you, and hopefully some of the kind of follow up on some of these patient cases is interesting as well. And then Dr. Richards will chime in, or Lauren will chime in anytime they have kind of something to add. So, all right. So the first kind of bucket of cases that we're going to talk about are opioid overdoses. There was a whole slew of these in the past month, more than I remember seeing the month before. And obviously, I've only been with you guys for a couple months, so I don't know how often you typically see them, but it seemed like a decent enough number that it was worth at least talking about this protocol. So we'll go through a couple of these cases. So first was a 47-year-old. On arrival, the patient was found unresponsive, being pulled out of the passenger side of the vehicle by the police. On initial assessment, they were breathing spontaneously, but had shallow breaths. And this is more than 10, but I think they meant less than 10 breaths per minute with a strong carotid pulse. The patient was pale, cool, diaphoretic, and pupils were pinpoint bilaterally. They had their breathing assisted by bag valve mask and oxygen 15 liters per minute. And then the patient was given 2 milligrams of intranasal Narcan with a nasopharyngeal airway placed after that. Respirations improved, but EMS continued bagging with bag valve masks while the blood glucose was assessed. During this time, the patient remained unresponsive, vitals, oxygen, and tidal, and continued bag valve mask was done. Attempted IVs without success, and then the patient had not regained consciousness at that point, and so an additional 2 milligrams of Narcan was re-administered intranasally. And the patient was transferred to Westchester. Before you left the parking lot of the business, the patient regained consciousness. You told him they'd overdosed, and he agreed to transport to the ER. So the initial vitals listed for this patient were blood pressure of 137/70, heart rate of 109, shallow respirations, 94% on oxygen, and a GCS of 3. So a couple of things about this case that I thought were great was that you noted that you assisted with bag valve mask right away. So obviously, while someone else is working on the Narcan, step 1 is just to support this patient. You could keep supporting them a whole long time as long as you keep them breathing until you get Narcan in them. So that's definitely step 1, is just to get in there and support their airway. I thought using a nasal airway was a great choice. Obviously, you don't want to use an oral airway in these patients because although they're altered, they're not totally out. And the plan is that they're probably going to wake up at some point. So they usually do have a gag reflex, and so an oral airway would be potentially dangerous, but a nasal airway is a great choice. And then the timing of these Narcan doses, I think we're about 7 minutes apart. And so intranasal Narcan is going to take a little bit longer to act than IV Narcan. So you want to be careful of dosing it too quickly. And so that was another kind of good point in this case. The one thing that we'll talk about as we kind of go through these and when we look at the actual protocol is that level of consciousness is not actually the indication for Narcan administration. It's really respiratory rate. So you don't need to get these patients, to the point where they're woken up and rowdy and going at you. You really just need to get them breathing adequately. And so when thinking about kind of the indications for redosing Narcan, a second set of vitals, stopping bagging to see kind of what their true respiratory effort is and what their respiratory rate is can be helpful so that you don't have to kind of continually redose. But otherwise, like I said, there were a couple of really nice points with this one. The second case was a 70-year-old male. On arrival, they're unresponsive on the floor, covered in vomit. The friend says that he just found him that way. once awake, the patient says he's got no medical history and this is his first overdose. He was originally found apneic, but with a strong pulse. Pupils were constricted. Blood glucose was 210, and vitals are there below, with sinus tach on his 3 lead. After the first Narcan, which was 2 milligrams of intranasal, the patient's work of breathing increased. And then after the second dose, they became alert and oriented ×4. So again, a total of 4 milligrams of Narcan in this patient's case, just like the last one. And at that point, the patient was able to stand and walk to the cot, and then he was transported without any issues. So blood pressure on this one, 127/81, a heart rate of 122, respiratory rate of 10, but noted that that was assisted, and then 100% oxygen while being bagged, and a GCS of 3. So similar kind of story in this case. It would be helpful to have kind of that second set of vital signs in between here to know really what the patient did after the fact. If a patient's respiratory rate increases to, in my mind, and Dr. Richards, feel free to comment if you have a different number, but over 12 or 14 times a minute, that's really my kind of threshold for giving more Narcan or not. Or you can, consider giving them a little bit of time, because that intranasal dose is going to take about 5 minutes to have an effect. So very similar kind of story and learning points on that case. The next case, sorry, my numbers are clearly out of order. This was a male. The dispatch was that they were not breathing with suspected opioid overdose. When you arrived, the patient was breathing agonally with a rapid bounding pulse, had sinus tach on a 4 lead, respirations of 4 per minute, began bagging with oxygen, administered 2 milligrams of Narcan intranasally, got an IV, and then 2 milligrams were given through the IV. He regained consciousness after that second Narcan. Basically, the patient said that they don't use drugs. They found some white powder, smelled it, and then threw it away, and then was declining transport to the hospital. So the crew advised the patient that he needed to be seen at the hospital for further evaluation. He denied transport. You advised him that he could die if he did not seek further medical attention. He said that he understood the possibilities and the repercussions. And when that conversation was happening, he was alert and oriented ×4 with a GCS of 15. You again recommended that he seek further medical attention, but he continued to refuse, and you had a witness there for the refusal. So very similar vital signs to the other cases, but this highlights kind of what the policy is around patients refusing transport, particularly in an overdose situation. So it really, based on the documentation, really sounds like you did your due diligence in terms of assessing the patient's mental status. The only other comment that could be helpful is that the patient actually verbalizes back to you that they understand the risks. So sometimes I'll document that specifically, right? So I told the patient X, Y, or Z could happen. They were able to repeat back those same things to me. And that gets at not just, are they awake and alert, but are they comprehending kind of what it is that you're telling them. And it is really important in these cases to try and get folks to medical care, because Narcan can often be more short acting than whatever drug it is that they took, right? So if they still have a dose of fentanyl or morphine or oxy or whatever it is in their system, and that's going to be acting potentially for, on the order of hours sometimes, that Narcan may wear off, and then they may go straight back into that altered or overdose state. So that's why it's so important to recommend that these folks kind of get continued medical care so that they can be observed for a little bit longer and make sure that they don't basically rebound off of that Narcan. But again, other than specifically documenting that the patient was able to verbalize the risks or benefits of transport, I think you did your due diligence, and this seems like an appropriate kind of, not appropriate refusal on the patient's part, but an appropriate documentation of how and why that patient refused. And then this is the last case. So the dispatch was for someone who was sick or ill, but on scene, the patient was found under the care of their staff, sitting in the backseat of his family car, responsive to verbal commands. This was after staff had given him 4 milligrams of Narcan through the nose. The patient said that the family took fentanyl in the past and had usually snorted it. And in talking to the patient, you were able to have him actually walk from the car to the cot. You needed to talk to him the whole way to remind him of what he was doing and kind of get him there, but he was able to ambulate under his own power. And once you got him there, you took him into the squad. In squad, the patient's vitals were taken, and he was placed on end-tidal and oxygen. The vitals, the only vitals that I have on this chart are a blood pressure of 113/77, a pulse of 72, a respiratory rate of 12, SATs of 94% on room air, and a GCS of 12. But the patient was given an IV, got Narcan, initially 1 milligram, then another milligram, and finally another 2 milligrams, in addition to some Zofran. So for this patient, if they are alert enough to ambulate, if they have a respiratory rate of 12, then this is a situation where Narcan actually would not be indicated at this point. Certainly over the course of transport, something may have changed with the patient's respiratory rate or their mental status. But remember that the indication for Narcan is really respiratory drive. So if they're protecting their airway and have good respiratory effort and a near normal respiratory rate, then those patients do not need to get Narcan. And then the other thing is that you can even start at a lower dose. So you can start at 0.4 milligrams of the Narcan based on the protocol and really work your way up from there. So I think, the fact that you started low and went up was fine. But for this patient in particular, based on what's charted, it's not clear that Narcan was absolutely necessary. Dr. Richards, do you have any comments on those cases?
No, I mean, really, really good case series here. I mean, the things that just kind of come to mind for me are, especially with like that 70-year-old, is just make sure that and I mean, he did this on these cases, but just another reminder that keeping that differential broad is really important, right? And so there's a lot of things that can mimic opiate overdose, stroke, basilar artery occlusion, hemorrhagic stroke, other toxidromes, clonidine intoxication, even if it's like someone has a history of opiate use disorder, going to like Lumiere. I mean, that could have been, especially with like 4 milligrams of Narcan, then we're starting to think about like, well, could have this been some other kind of overdose or concurrent overdose or these sort of things too. So just kind of keeping the differential broad. The refusal one, that seemed pretty straightforward, and it turns out it really was. And so I very much agree with offering transport, but good documentation that once the naloxone reverse what it needed to reverse, and then kind of being on your way after a good discussion is a nice approach. So this is a good mix of kind of a lot of different considerations, all boiling down to naloxone, but good job keeping the differential broad. So
yeah, and there were more than this last month. So you guys saw a ton of these patients, and sometimes they can't seem to come in batches. At least they do when I'm in the hospital as well. So Dr. Richards' point about just kind of thinking about other stuff, especially if you're in a strange age range or the story doesn't quite make sense. So this is the opiate overdose protocol. So a couple of things just to point out here. If the patient's stable, able to maintain their own airway with normal hemodynamics, then your management is really supportive. So oxygen and kind of close monitoring. If you need to assist them in any way, then your first go-to, and you did this in all of these cases, is to go to managing the airway with bag valve mask ventilation, a nasal and oral airway, probably leaning toward a nasal airway if you're about to give them Narcan. And you don't need to move on to advanced airway management, so specifically an LMA or intubation until you've tried Narcan. So continue supporting with bagging, use your adjuncts, and that should be the first thing you go to, which you did in all of these cases. And then a quick note about actually administering Narcan, the way that it's written in the protocol. So you want to, regardless of your dose, you want to split that intranasal dose between both nostrils so you can maximize the surface area for absorption. And if you are giving a larger dose, then don't give more than 1 milliliter in each nostril. But even if it's a small dose, best practice is to give it on both sides. That way you get good absorption of the medication. And then the clinical indication, the clinical goal of naloxone is improvement in the patient's respirations, not complete resolution of their mental status. So this is what we discussed with a couple of those cases, that you can start low and work your way up. The point of that is so that you don't get negative side effects, basically with immediate withdrawal side effects of the opiates, and just really paying attention to what is their breathing doing. And that should be your clinical marker about whether or not more Narcan is indicated. And I also mentioned that intranasal can take a little longer to act, on the order of like 5 minutes rather than IV, which will take a minute or two. And then if your patient is completely apneic or peri-arrest, so you have bradycardia, hypotension, other signs of shock, then that's when you want to just go straight for a higher dose of Narcan, and just get yourself basically the best bang for your buck as soon as you can. But those are the points on this protocol that I think were highlighted through some of these cases. So that's what I wanted to kind of point out. And then the final thing is that your max dose is 10 milligrams. So keep going until you hit that. But for the most part, I think you'd probably be able to make it to one of your local hospitals before you get there for most of your patients. All right. So the next kind of bucket of cases to talk about are in sort of like a pediatric.
You know, that you can kind of make one more comment, and just
sure.
so that it's said, while and just for folks to be aware of kind of additional resources, there's going to be increasing probably chatter about this specifically in the pre-hospital setting, but in addition to just like airway monitoring, respiratory monitoring for patients who receive naloxone, for some patients with opiate use disorder, this could be like an entry point into like recovery. Westchester Hospital, I actually don't know about the other hospitals that you guys transport to, but Westchester Hospital has an increasingly robust program. UCMC is like really good about doing buprenorphine, which is kind of like a partial opiate agonist, which is it kind of like quells the cravings and kind of hits those receptors and can help medication assisted kind of therapy for opiate use disorder. And you know, it may not be the first time they get naloxone, but it might be the third time where they're kind of like, all right, you know what, maybe I want to take a step in that direction. So even if it isn't necessarily for the respiratory monitoring components of it, though it oftentimes is, just know that there's other things that happen or potentially could happen that are good for these patients, even if they do end up getting transported. So just for kind of situational awareness to everyone.
Yeah, thank you. Yeah, this is one of those moments in a patient's life that sort of, you know, like something has gotten so bad that an intervention like this has to happen, that is actually a good opportunity from a healthcare perspective to kind of lean in on that stressful event and use it as an opportunity for change for the patient. So that's sort of, I think, the underlying theory around starting these programs for recovery in and around events like this. Although you might think like, wow, something just major just happened, let's just deal with that. But in situations like this, it can actually be a good catalyst for patients for change. Cool. So for those of you guys who don't know, I'm actually a pediatric doc, so I work at Children's and at Liberty. And so I've started reviewing PEDS cases as part of CQI. And so I'll try and kind of bring the knowledge that I have that's better about pediatrics, and let Dr. Richards talk about the stroke cases that we're going to talk about more, just to kind of bring a little bit more of that into you guys. I know it's not super high volume, they can be super stressful, and we are entering respiratory season. I think there is actually going to be a season this year, unlike what there has been for the last few years, where there's no rhyme or reason to when kids were getting sick. So the next couple of cases are going to touch on some of the pediatric respiratory protocols. All right. So the first is a 16-year-old. You're dispatched for difficulty breathing to the Little Clinic. Patient came in with difficulty breathing, said he felt like he had a cold or allergies the day before, but Dayquil made him feel better. Today, his breathing problems worsened. They're doing renovations in his house. And the NP at the Little Clinic administered albuterol, and his condition became worse. He became diaphoretic, so she stopped the treatment. The patient's sister is the one who's around and said she actually had the same response to albuterol. He has had an asthmatic episode when he was younger, but doesn't have an inhaler. And when you arrive, the patient's found sitting in the doctor's room, alert and talking, but lethargic. ABCs are good, clear lung sounds. Radial pulses are there, but weak. Skin is normal, cool, and diaphoretic. Pupils are equal round reactive. He has no chest pain, and his difficulty breathing has subsided a little bit. His capnography is in the 30s, his oxygen's in the upper 80s, until he was placed on oxygen. And he said he felt like he was out of breath. It felt like he was out of breath when he was running. And there's no obvious signs of trauma, and he feels a little lightheaded and dizzy as well. So this case is a little bit challenging because the patient's a little bit all over the place, right? Lots of kind of respiratory type symptoms, but he's also lightheaded. He also got this albuterol that he didn't seem to respond very well to. And then there's kind of like nebulous history of like sort of had an asthmatic past, but doesn't carry an inhaler with him. It's not an uncommon story. And so from an ER perspective and a hospital perspective, we're trying to tease apart like what really is the patient's respiratory history. But you don't necessarily have, the time or the resources to do that on scene. So it can be difficult to tease these kids apart. A couple of things about this kind of physical exam to just think about, alert and talking and lethargic don't really go together. So if you're lethargic, you are super out of it, tired, hard to arouse. So I would say that they're tired appearing, but awake and interactive, or talking and interacting with me, but tired, something like that. Just to make it clear of like really what is this person's mental status, because lethargic is going to put them into a very different kind of bucket of things. And then certainly appropriate management in terms of taking a patient who is hypoxic and putting them on oxygen. So the follow-up, I'll talk about the follow-up for this patient first, and then we'll go into the pathway or the protocol for this. So you guys took this patient into Children's Liberty there. They got albuterol and steroids in the ER, seemed to be doing a little bit better, so were discharged home. 2 days later, they came back with a very similar presentation, and at that visit were admitted to the hospital for an asthma exacerbation. The thought process was probably that he had maybe a virus plus this sort of like dust exposure in the context of his house being renovated. So maybe a couple of different hits that made this kid sicker and meant that his, if he's got dust in his home and that exposure is continuing, he's not necessarily going to get better right away. And so this patient actually ended up being admitted. In terms of protocol and assessing patients with respiratory distress where you have a concern for asthma, there is a scoring tool. So you have the PRAM score that can help you figure out, how severe is this patient's illness. The things that I really want to kind of touch on is retractions, especially in pediatric patients, looking at the neck to see if they have either suprasternal retractions, which are sometimes called tracheal tug, but kind of right in the middle, or contraction of the scalene muscle, so kind of off to the side here, really pulling where you can see the outline of those muscles every time they take a breath. So both of those are pretty significant signs that a patient is having increased work of breathing, difficulty breathing. And then in terms of what they actually sound like, air entry can be extremely hard to assess, especially if you're, using one of those little stethoscopes. So this can be quite challenging. And then when it comes to wheezing, the issue is that you have kind of both ends of the spectrum sound the same. So a patient who is fine doesn't have wheezes. But a patient who is, totally in extremis, can also have a silent chest or no wheezes. So listening is helpful. It's a piece of information. You're probably not as kind of like up to date or in tune with listening to kids all the time. So really look at what their work of breathing is. Can they talk to you in useful sentences, or are they speaking one or two words at a time? Are they using all these extra muscles to breathe? If all of that is happening, they're using extra muscles, they can't talk to you except for a couple words at a time, but their chest sounds okay, I would really anchor my kind of thought process and treatment based on their work of breathing. Because I think this bottom half of the scale is kind of difficult to tease apart sometimes. But if you're able to do the pram and you get a score, then there is pretty good kind of stratification in terms of management of these patients. It all starts with either nebulized albuterol plus minus Atrovent, or a spacer if they have their spacer, with like a regular inhaler, and then steroids. So again, this patient was tricky because this kind of remote history of asthma in someone who doesn't carry an inhaler with them. I don't know that I would have, I don't think it's required that you give that patient steroids in the pre-hospital setting. But a similar patient who, has had a couple of asthma attacks in the past, carries an albuterol inhaler, steroids can be incredibly helpful. You are not going to see an effect of the steroids right away. So it is not going to turn that patient around, but it will potentially avoid that patient and that family needing an admission. It will potentially decrease how long they're in the ER. And so it's a really helpful therapy in the pre-hospital setting to kind of get these kids turned around and breathing more comfortably a little bit faster. But do recognize it's not gonna have the effect of albuterol, it's not gonna have the effect of Narcan. You're not gonna see some magical change when you give it. But especially as we get busier, as these patients get put in the waiting room rather than directly into a room, if there's an hour or two goes by before they're assessed, then those steroids might be the difference between that patient having to stay in the hospital or being able to go home, which is huge for the patient and the family. So that's our asthma management protocol. Yeah, Dr. Richards.
And I'll just kind of highlight that one last thing. So yes, it does take a little bit of time for these medications to kick in. And I'll just kind of highlight that rightmost arm. So if you need something to kick in right away, you got epi too. So it's a good bronchodilator, and you have a really powerful bronchodilator at your disposal if you absolutely need it. Yeah,
definitely, and it's a great tool, especially for those patients that fit in this bucket. Lethargic patients. You should be breathing hard and fast rather than not breathing very well at all. And so if they've gotten to this point, then they're pretty far along that disease course, and IMEPI can be extremely helpful. All right. See if it'll let me get back. There you go. And then the final thing I wanted to comment on, so your medication doses are all weight-based. So just a quick comment on the Broslow. If a teenager knows about how big they are, great. Also, they're going to be adult sized, so that's fairly easy. But if you have a smaller kid that you need to think about weight-based dosing, just remember red to head. So this little arrow that's on the end of the Braslow tape is what goes to their head. And then when you get to their feet, you're looking at what color they match up to in terms of your estimated weight and doses. So just a comment on that. All right. This next case is for a 9-month-old where there was concern for choking. Patient's mother said she came home from the grocery store, sat the patient down on the carpet while she was putting groceries away. Then she heard him cry, but the cry didn't sound totally normal. And she went to check on him right away, could tell that he was choking on something. She performed a finger swab and felt something hard at the back of the throat, but couldn't get it to come out. And while she was attempting to get it out, she believes that she pushed it further down. The mom states that the choking episode lasted about 15 seconds before the patient's crying returned to normal and then was breathing much better. Vitals were a respiratory rate of 30, 100% oxygen in room air, heart rate of 134 and regular, and the patient was breathing normally during transport, smiling and acting appropriately. This patient was taken to Children's Liberty, pretty similar presentation when they got there. I think the most important things are that the patient was comfortable with a normal respiratory rate and normal oxygen sats. But they did get an X-ray based on that story. And you can see this kind of like round white object, probably beginning of the small intestine or end of the stomach. And then they measured it there, so 15.5 millimeters. So about a half an inch in terms of the size of this object. And so this patient, after getting that X-ray, noting that there's nothing higher up, nothing in the respiratory tract, and that it's already in the stomach, was discharged home. The type of foreign body that we really get nervous about, especially if we don't know exactly what the kid ingested or what they might have had access to, are button batteries. So the next slide is basically just a video, I think it's done by the Maryland Poison Control Center, just to show you what happens with a button battery and why they scare us so much. And then we'll talk about the protocol after the next case. So hopefully it's going to play. There we go. So there's no sound to it, but like it says 25 minutes of a time lapse, and they basically just took a button battery and stuck it in a hot dog to kind of mimic what would happen if a button battery was stuck in the tissues of the throat or the esophagus. So literally, that button battery, if that's what it is kind of like cooking the insides, and can have some really, really serious complications for patients depending on where it gets stuck. So in a situation like this, where mom sort of knew that something had happened, like really has high suspicion, and the kid had an obvious choking episode, we always X-ray those kids. We always take a look and try and see what we're dealing with in case it's a button battery. And then certainly if parents know that it was, then we assess those patients even quicker. So I just always think that video is kind of interesting. The next patient was a similar case, so a 1-year-old this time, with concern for choking on an apple piece. This patient turned blue around the lips and mouth, and the patient's family stating that the child finally threw up and spit up all of the apple pieces, after which they're breathing normally, acting normal with good color. There was a language barrier, so the 9-year-old was interpreting for the family, and on assessment of the patient, they had good breathing, good color. They were crying, acting normally with clear lung sounds. no shortness of breath, no loss of consciousness. And the patient's family wanted to go to Liberty, and they didn't require any other treatments en route. This patient also got a chest x-ray at Liberty, and it was normal, and the patient was discharged home. So in cases like this, you know, you never know if everything really did come out when they threw up, or if there's something that actually found its way down into the lungs. And so that's why we x-ray these patients. So I'm not going to see a piece of apple on the x-ray, but I am going to see if there's something that looks like the lung is collapsed behind, you know, an obstructing object. If it was a really high obstruction, they can have fluid buildup in the lungs after an event like that. So we do monitor them, watch their respiratory status, watch their oxygen, and get an x-ray. So even in cases like this, it's helpful for us to see them. So the pediatric respiratory distress protocol for obstruction or foreign body is here. In terms of exam findings, you may have decreased air movement on one side, unilateral lung sounds. They may have retractions or accessory muscle use. They may have drooling. So particularly when a foreign body is lodged up high, those patients often will be kind of sitting forward and drooling. If you don't have kids of your own, it might be hard to tell what a normal 9-month-old drooling is, because they're going to be drooling as well. But if they're like cooing, babbling, interactive, smiling, and have a little bit of drool, that's not really what we're referring to. Drooling is really like they often will be breathing with their mouth open, clearly not swallowing any of their secretions, often kind of sitting forward or sitting up, not looking like they're in a normal, comfortable position. And then on the severe end, cyanosis, hypoxia, or unconscious as a result. So those may be signs of foreign body obstruction. In terms of management, if they're awake, do your standard BLS care, so back slaps and chest thrusts for an infant, or the Heimlich for an older kid. And if they're unconscious, then starting CPR, starting bagging. And if you can identify a foreign body and remove it, then obviously do that. But it all depends on what and where the foreign body is for how these kids are going to present. And just like you did in these cases, just have sort of like a high index of suspicion for something could still be in there, or we don't know what they got. We don't know where it's stuck. Because we will, for the most part, x-ray all of these kids and try and get to the bottom of what happened. Neither of these kids were super sick, so I don't have any kind of other comments about the management, but did just want to touch on this protocol. So any other comments, Dr. Richards?
Yeah, I think the only thing that I'll make and emphasize again, kind of what you mentioned, is you never really know what the kid probably took in. I mean, who knows if there was like a penny right next to the apples or something like that, right? And so and who knows if that penny is really a button battery or 2 magnets or something like that. So certainly we always advise transport. If you have a good and reasonable conversation, the kid looks okay, then I guess they could refuse, but ultimately, like, it really is best for these kids to get checked out, both for the ingested material, but then also, like, if they did get back blows, or for the one who got like the finger sweep, like, all that stuff should get checked out one way or the other. Like I said, we're not necessarily calling CPS if the kid looks really good and they spit up like a hunk of apple or something, but still, even in those situations, like, we recommend transport and then further observation for all the reasons we already talked about.
Yeah. And I've been surprised sometimes what sorts of things our gastroenterology doctors are will kind of go after, and what they'll actually try and retrieve from a patient's stomach or esophagus. So yeah, sometimes I'm surprised that they'll go after certain things versus not others. So it's always helpful to have them checked out. All right, the last case is not from you guys, but from me. So I worked an overnight at Liberty a couple of days ago, and right around the 2 to 4 a.m. hour, I got about 6 of these patients, right, one after the other, who all had virtually the same story. So you're gonna see them because they're gonna wake up in the middle of the night and probably call 911 in several circumstances. So let's say it's a 4-year-old woke up with a coughing fit at 2 a.m., couldn't catch their breath, had really noisy breathing. Looks a little bit better now, but the parents were super concerned, mostly because of how hard they were breathing around that coughing fit. When you dig into the history a little bit more, they say, yeah, it's like a really harsh or barking cough. And so that puts you into this pediatric stridor protocol, which is really about managing croup or epiglottitis. So stridor is high-pitched noise that usually happens when you're breathing in. And the noise is literally coming from swelling or obstruction of the upper airway. So whatever sort of caliber airway you have has been narrowed, and so now you're getting this high-pitched noise. There is unfortunately a broad differential diagnosis, which is why this protocol is symptom-based. But the sort of main diagnoses are usually going to be croup, more rarely epiglottitis, but is a major emergency if that's the case, and then foreign body. The mainstay of treatment is really just supporting the kid and not trying to do too much to them, and actually really trying to keep them calm. So try and keep them with the family, keep them in a position of comfort. If you need to give them oxygen, see if the parent can help you, and do everything you can not to make them more upset. The more upset they get, the worse that noise and the worse that obstruction gets. Sorry, I have IT here, probably, with my computer. Hi, thank you. I appreciate it. You're welcome. Sorry, guys. My computer's not been working for weeks. So yes, like I was saying, just keeping the kid calm, and if you need to, let the parents help you out or the caregiver help you out in terms of giving them oxygen. And then the other kind of management options that you have, again, are fairly limited, but you can do normal saline via nebulizer, and you can call medical control to get instructions for nebulized epinephrine, which is really the quick answer to croup in particular, which is a viral infection kind of around the voice box. So the way to make nebulized epinephrine is taking 0.5 of the 1 milligram per ml. So your vials of epi that you would usually have to dilute if you were going to use it for cardiac epi. So taking half a milliliter of that, adding it to 2.5 milliliters of normal saline, and then putting that in a nebulizer to nebulize. But to get those instructions, you have to go through medical control, and so you're really relying on kind of supporting the kid get through this. Croup in particular, it's a viral infection. It always hits in the middle of the night, so you're going to get these calls at 2, 3, 4 a.m. Your body normally makes steroids, and those steroids go down kind of and dip in the middle of the night. So the story is pretty much universally a kid woke up in the middle of the night with a bad coughing fit, really noisy breathing, and everyone got super freaked out. So we give them steroids, we monitor them. If they are having stridor, we give them racemic epinephrine, sometimes repeated doses, and that's the management for these patients in the hospital. So you're going to see this, I think, probably a ton coming up here over the next couple of months as we move into sort of viral respiratory season for our kids. We're seeing a lot of it, just as they've gone back to school even for the last few weeks. So any other thoughts or comments on that one, Dr. Richards? Yeah, cool. All right. So we're going to leave my comfort zone and go squarely into Dr. Richards' comfort zone and talk about some stroke patients. So the first one is a 61-year-old male presenting with stroke-like symptoms. The staff at the facility that he's at actually said that he was admitted there 1 week ago for rehab of a prior stroke. They checked on him this morning, found that he had altered mental status and unequal pupils, and the staff reports that he was last seen normal about 12 hours ago. They gave you paperwork from his last admission. And on arrival, the patient's in semi-Fowler's in the bed, alert to self with a GCS of 7. It was 1 for eyes, 2 for verbal, and 4 for motor. Skin's okay, airways patent, respiratory rate's normal. Pulses are good, perfusion is good. The right pupil is dilated and not reactive. The left pupil is constricted and not reactive. And the Cincinnati Stroke Scale is non-conclusive as a result of the mental status change. So got vitals, got a 3 lead that looked like sinus tachycardia and a blood glucose of 198. Transport to Westchester with stroke alert suggested, and you guys went straight to the CT scanner. So a couple of thoughts or questions on this case. Really, one is, what are the limitations of the Cincinnati Stroke Scale? When can you use it? When can you not use it? And what other kind of options do you have in a patient who's altered? So I'll let Dr. Richards talk to that.
Yeah, I mean, so technically, you still can certainly do a Cincinnati and a CSTAT in someone who has decreased mental status. It's just considered abnormal. So the kind of the gold standard exam that they'll do in the emergency department is something called the NIHO scale, which is, a series of exam findings. We boil it down into CPSS and CSTAT. But I mean, if they are kind of like obtunded and you put your arms up and it goes right, well, that's just an abnormal arm exam in that situation. This is probably going to be a little bit more pertinent come next calendar year when more kind of comes out about like hemorrhagic stroke guidelines. So we'll have to kind of stay tuned and see how this all fits in. But the reality is, if their GCS is 7, they're not going to be able to like keep their arms up. You do it anyway, it falls right back down. Well, that's an abnormal arm exam then in that situation. Now, of course, your specificity goes down in terms of like really knowing that this is a stroke or not. But if this is a hemorrhagic stroke or a basilar artery or something like that, that is you can 100% put down what I just said. But that said, we call it as a stroke code. Ideally, they go straight to CT. So, the same thing happens at the end. Just don't feel that there's hesitation to documenting an abnormal stroke scale just because they can't follow your instructions.
Awesome, super helpful. The patient ultimately did get their imaging at Westchester, but the stroke was not the issue for this patient. They were actually found to have hypoxic respiratory failure and had bilateral pulmonary emboli, so clots in both lungs, and were admitted for anticoagulation, and then eventually discharged to a SNF. So, looking, at this patient and kind of imagining what I might have been thinking on the scene, I mean, that there's a risk, or that he had a recent stroke. He's got a grossly abnormal neurologic exam. It sounds, one question could be on scene, what is his pupil exam normally? Because looking at this, I was worried, could he have actually had a hemorrhagic stroke now, depending on what his initial stroke was. But have his pupils always looked like this, or are they totally different today from yesterday? I mean, based on the staffing, you may or may not be able to get a good answer on that. But his altered mental status and abnormal neuro exam definitely should push you in the direction of stroke. And then thinking about vitals, I mean, you guys got a normal oxygen saturation and a relatively normal respiratory rate. So he must have kind of been progressing or changed in the hospital, but he was tachycardic, and so that can certainly be a sign of pulmonary embolism. But these are not the most abnormal vital signs other than his mental status. So I think the thought process here and getting him straight to the CT scanners is certainly a good idea, and probably what I would have been thinking as well. So kind of a strange conclusion to this case, not what I was expecting, but good good information nonetheless.
And the two additional things that we see common stroke mimics in someone who has an old stroke, one is recrudescence. So the stroke symptoms come back or worsen in the context of systemic disease like a UTI, pneumonia, PE. But then you can also have focal seizures. I'm not necessarily advocating that like we give everyone with like a recent stroke and worsening neurological signs and symptoms like benzodiazepine. But if you do see like, rhythmic movement in the arm, it may not be the worst idea. With someone with a GCS of 7, I'd probably honestly talk to like online medical control just so everyone's aligned before giving benzodiazepine. But like if this person was like, you saw like rhythmic movements in whatever affected side it was, and they have this all presentation, as part of a pre-arrival, say, I don't know, maybe this is a seizure, like, do you want us to give them like a little bit of benzodiazepine? You may or may not get approval, we may or may not be doing it, may have the patient come in, make sure there's not a hemorrhagic stroke, and then go from there. But just another thing to at least have bore in mind if you end up seeing that.
So the next patient is a 36-year-old with concern for stroke. On arrival, the patient is alert and oriented ×4, sitting in their vehicle. They'd been found by a coworker who described the patient as not acting normal. The coworker explained that the patient was struggling to get out of his vehicle, had slurred and garbled speech. And the coworker, after talking to dispatch, who kind of asked about stroke symptoms, also noted that the patient had right-sided weakness in his arm and right-sided facial droop. The patient's speech and motor function had improved by the time of EMS arrival, but still had some weakness in the grip strength on the right side. The patient denied any past medical history or ever having symptoms like this before. Got vitals and a blood glucose, and the patient was noted to be hypertensive, but otherwise within normal limits. And then the stroke scale was reassessed to be positive for right-sided deficit and slurred speech. Once they were with the medic unit, patient was transferred to Mercy Fairfield, stroke alert activated, and he tolerated the transport, but while he was kind of talking to his family on the phone, the providers noted that he was slurring his speech, and he subjectively said he couldn't feel the left side of his body, but repeatedly the providers noted that his deficits were on the right side, and on arrival went straight to CT. His vitals are impressive, so blood pressure of 195/105. On repeat, it was same thing, basically 187/129. His heart rate was borderline tachycardic at 98. Normal oxygen saturation, normal blood glucose, and his GCS was 15. So unfortunately, because this patient went to Mercy Fairfield, we don't have follow-up on him, but feels like a pretty concerning story, especially with his degree of hypertension, but also a little strange for supposedly an otherwise healthy 36-year-old. So it would have been really interesting to see kind of what happened with this patient. But I think this is a good opportunity, Dr. Richards, to kind of talk about Cincinnati stroke scale versus the C-stat, when they each are indicated, and kind of what you're hoping for in terms of documentation from the crews. And I'll skip forward to this, hopefully helps.
Yeah, so this is so if the Cincinnati stroke scale is abnormal, we should be doing a C-stat. If the C-stat is 2 or greater, then we want, ideally, all other things being equal, the patient should be at a level of care where if there were to be a large vessel occlusion, there aren't delays in getting up. And that's all predicated on the time from interfacility transport from a place that can do thrombectomy to not. Now that gets balanced a little bit in terms of like, well, if you drive downtown to UCMC versus bypassing Westchester, you do have an increased time oftentimes from door to thrombolysis. While that is kind of a general assumption, honestly, probably the exact time is not lengthened exactly by the time. that you're transporting just from an operations perspective. Like it might actually be quicker to be down there. The flip side of this, though, is that there is some data about hemorrhagic stroke patients not doing quite as well. If you have to drive that half hour down I-75 and getting aspiration pneumonias and all the rest. So it's a little bit of an evolving picture. Kind of where we've settled on is that probably and then I'll take a step back. So this is all the bypass to a further higher level of care does have a time qualifier in it, which is about a half hour. What we have kind of settled on, generally speaking, is that probably in most areas of the township at most times of day, you're probably going to be going to the closest stroke center. But if you are in a position where, especially, you're kind of south and you can make it down to UCMC in a pretty reasonable time, traffic and all the rest, 100% that would be supportive. And that if that patient ends up having large vessel occlusion, they will get that treatment sooner. Then they're also in the right spot neuro ICU wise if they have a hemorrhagic stroke. So that's kind of what informs the protocol. That's the current AHA recommendation, but there's a lot of subtlety and complexity to it that's still, to be perfectly honest, evolving.
Yeah, I think this, from my perspective, as someone who clinically doesn't see but one stroke a year, probably, there's a lot to think about with these patients, and a lot to consider. And when you're tying that into considerations about kind of what the capabilities are of the center that you're transporting to, how long that transport time is, I mean, there's a lot to think about here. But do remember that the sort of second step in the process, if you have a positive stroke scale, is then to do and document the CSTAT. So in the cases that I reviewed, you guys universally document the stroke scale, and you put kind of why it was positive, so that it was the right arm, or that it was the face, or whatever it was, and that's fantastic. So keep doing that. But if you get to a positive, just remember to think about these couple of next steps and do a couple of other physical exam maneuvers to get a little bit more information. Cool. So yeah, very interesting in a patient that age to think about what might have been going on. All right, the next is a 72-year-old male dispatched for a stroke. Wife said that he started having stroke symptoms at about 4 o'clock, so he got last known normal, which is great. He has a history of blood clots, super important to know, history of previous stroke, and then it seems, based on this, it's still medical history, like underlying right-sided weakness and hypertension. Patient was sitting in his chair, alert and oriented ×4, good airway and breathing, clear lung sounds, decent radial pulses, skin was normal and dry, pupils are reactive but sluggish, and then he did have right-sided weakness, right-sided facial droop, and slurred speech, and just generally weakness on the right side, and then that gave you stroke signs positive per the Cincinnati Stroke Scale. No chest pain, no shortness of breath, no difficulty breathing. And while he was in your care, the arm drift improved somewhat, and his leg weakness improved as well. He did not have any headache. In terms of interventions, blood sugar was 122. The 3-lead had some artifact, but no ectopy. And then stroke sticker was filled out and placed on his t-shirt. And the hospital was notified ahead of time about a stroke alert, met with the physician in the ER, and took the patient straight to CT. This patient also had significant hypertension with a blood pressure of 204/109. The repeat was 198/89, heart rate of 64, respiratory rate of 12, sats of 95%. The blood glucose we already mentioned, and then a GCS of 15. So this patient, in terms of their findings on CT, he had multiple prior strokes, but with the right-sided weakness and dysarthria, went straight to CT and had a left ICA occlusion. So that's what this arrow is pointing to here. So significant left-sided stroke. He was admitted to the neuro ICU, transferred to UCMC for further management. He was not a candidate for TNK because of his underlying anticoagulant state, so probably on anticoagulants with that history of clots, and no endovascular treatment was indicated because of his low NIH stroke scale, which Dr. Richards mentioned as our kind of stroke screen in the hospital. And then he was able to be discharged to rehab. So this is a case of kind of like legit concerning signs and symptoms, even though they seem to be improving a little bit in Root, who had a pretty major stroke. So again, same kind of comment with the last case, like good job going through the Cincy stroke scale. Just think of that kind of additional next step. And then I didn't actually know what a stroke sticker was. So I don't know if Dr. Richards wants to comment on that or comment about, you know, whether you want that on all patients or when it's indicated.
Lauren, are you there in the room? You want to talk about the sticker?
Yeah. Yeah, she's in the room.
Oh, you can hear me?
Yeah, we can hear you.
Oh, great. Okay. I was waiting for him to take mute. So yeah, you guys have, I think, heard me go blue in the face about stroke stickers, and you guys do a relatively good job about it. So these are just stickers that help the continuum of communication from on scene all the way through discharge of the patient. So just like you guys would be inputting information into your reporting system, you can fill out the sticker at the same time. Basically just has the important stuff that we want to know when like calling in a stroke patient. So it also helps you with Brady report, but it has last known well. It has a place for a witness name and phone number, which is really helpful. So in case family members are like kind of dragging behind and the patient comes to the hospital and we want to ask more questions, we can easily contact somebody. It has a finger stick blood sugar on there. It has also has a list of blood thinners that you can check. Because once again, if your patient can't really communicate that well and they show up to the ER alone, and for some reason it just slips your mind to like let us know if they're on thinners, so you can easily just look at that sticker and know. But basically, the sticker will follow them all the way through admission and discharge, and it basically stops the telephone game. So you guys tell the charge nurse on the phone one thing, she tells the doctor another thing, you know, things get lost in translation. So it's just a tool to help improve communication. And yeah, any stroke patient that you guys think, even if you're suspecting a stroke or, you know, they're kind of a obvious stroke, just stick it on the patient's shirt and we'll easily peel it off and put it on the patient's gown.
Thanks for using it and thanks for writing it down. That's awesome. Good
Yeah.
job.
I think it's, I mean, anything that can decrease kind of your mental burden when you're trying to give report or handoff is super helpful. So I love the idea of it. And also gives you kind of all the pieces, all the high points of pieces of information that you need to know. So one of these cases, I think there was not a last known normal documented. In this case, you have a history of blood clots, but actually kind of looking and seeing, were they on blood thinners? Obviously, I can't see the sticker to know if you check that off. It just didn't make it into the documentation. But, you know, having everything that you need to get through and need to ask about in a stroke patient in one place is great. It makes your life easier when you're then trying to remember things, you know, 10 minutes later. So cool. So that was that patient. And then this last one is a 58-year-old dispatched for possible stroke, has a history of stroke and a history of MIs. He started having abnormal sensations in his head and hand at 6:30. So good job with the time of onset there. So he contacted EMS. He is not on any medication because he doesn't want to be. On your assessment, he's alert and oriented ×4, GCS of 15, open and maintainable airway. Breath sounds were clear bilaterally, denied any shortness of breath. His skin was warm, pink, and dry. And he said that he's been having like intermittent chest pain every day. This patient was also hypertensive, and all other vitals were within normal ranges. Blood glucose was 114. He was negative on the stroke scale, specifically, good, strong, equal bilateral grip, pupils equal round reactive, and good pulse and sensation everywhere. By the time you got to Westchester, he was no longer having these abnormal sensations in his left hand and denied all medical complaints. And his vitals were blood pressure of 153/103, a heart rate of 104, respiratory rate of 16, SAT of 99, glucose of 114, and a GCS of 15. So this patient did end up getting admitted for MRA. That was negative, and so he was discharged the next day with a diagnosis of TIA, or transient ischemic attack. So pretty kind of consistent with having a negative stroke scale. He also had a normal stroke scale based on the hospital's assessment. And so this is not someone who needs to be a stroke alert. And obviously, if things are improving, then TIA is a likely diagnosis. Thinking about this patient and the one before in terms of sort of distribution of symptoms, having kind of weird sensation changes in your head and your hand, it's hard for me to figure out, what part of the brain might be affected to cause that. And so those symptoms themselves are a little less concerning than other stroke type symptoms, but still needs to be worked up that way. And then the patient before, they had right-sided weakness and dysarthria or slurred speech. And then it was documented right-sided facial droop, which usually I would expect the opposite side. So when you're assessing these patients, think about, what the symptoms are, what they are presenting with, what you're seeing on your exam, and sort of like, does it fit or match with what you'd expect based on a diagnosis of stroke, and that can help you kind of in your evaluation of these patients as well. But all in all, we wanted to make sure we kind of talked about the Cincinnati Stroke Scale. You can do it even if a patient is altered. So document their GCS, document that they are altered, but still try the maneuvers, and just document that they're all abnormal potentially. And if you do end up with a positive Cincinnati Stroke Scale, then move on to doing the C-STAT and kind of these other exam maneuvers. So having them actually look in all directions, holding their arm up for 10 seconds without letting them drop. And then what is their, are they alert basically to place and time? And can they follow your commands? So just a couple of extra steps, most of which you're probably doing anyway, because you're documenting their, that they're alert and oriented or not. So just a little bit more time to do those couple of extra exam maneuvers to get you the C-STAT. So hopefully it was helpful to hear kind of the follow-up on some of those patients. Some of them were pretty interesting. And those are all the cases and all the information that I have. So happy for Lauren or Dr. Richards to give any other comments. And if you guys have any questions, I'm happy to answer whatever I can.
No, nice job. Thank you, Dr. Cheatham. Any comments from any of the rooms there on the call? Cool. That's all I got.
Thank you very much.
All right. Thank you guys for your attention. Thanks for the care that you provide to our patients, and we'll see you next month.
All right. Thanks, everyone.